So the topic of today's topic is management of acquired mandibular defects. Mandible is a single bone that creates peripheral boundaries of the floor of the mouth, facial form, speech, swallowing, mastication, respiration. Disruption of mandible has the potential to disrupt any of these, and therefore rehabilitation of mandibular patient should consider both form and function. Surgical resection of tumors often includes a partial mandibulectomy resection, a partial glossectomy, a partial resection of the floor of the mouth, and a radical neck dissection. The extent of the surgery and effect of radiation therapy and chemotherapy determine the amount of rehabilitation needed to a patient. Oral reconstruction of patients with partial resected mandible is one of the most challenging procedures. Classification of mandibular defects is broadly classified into acquired, congenital, and developmental. Acquired again classified into marginal, segmental, subtotal, and total. Segmental is again classified into anterior body and lateral body to midline, which is again classified into body only, ramus, body with disarticulation. Now, congenital is divided into incomplete formation, and incomplete ossification. And then the next thing is developmental. Incomplete ossification includes hypoplasia, mandibulofacial dysostosis, etc. Developmental as a result of a postnatal insults, which is trauma during birth, surgery, etc. So based on the resection, Laney again classified it into continuity defect, that is the marginal dissection, and discontinuity defect, that is the segmental dissection. Continuity defects includes inferior border and its continuity preserved, no deviation, less facial disfigurement, occlusion rarely changed, and can be anterior defect or posterior. Discontinuity defects include complete segment from alveolar crest to inferior border removed. Mandible deviates to resected side, marked facial disfigurement, occlusion altered, can be lateral discontinuity defect, midline defect, but discontinuity defect. Now, according to Cantor and Curtis, which is given in 1971, it is class 1 is radical alveolectomy with preservation of mandibular continuity. Shown in the picture. In this case, tissue resection, portion of the alveolar process in the body of the mandible, lingual and buccal sulcus mucosa, portion of base of the tongue and mylohyoid muscle, lingual and inferior alveolar nerves, sublingual and submaxillary salivary glands. Sometimes anterior part of digastric muscle is also removed. Features includes least debilitating, sometimes resection of part of mylohyoid muscle and resultant scarring can raise the floor of the mouth, causing reduction in tongue mobility. Ability to shape and control the tongue form may be lost due to loss of some intrinsic muscles. Dissection of lingual and inferior alveolar nerves results in a loss of sensation of mucosa of cheek, alveolar process, lower lip, and loss of taste of anterior two-thirds of the. Class 2 is lateral resection of mandible distal to cuspid. Tissue resection. Condyle, ramus, and body of mandible distal to cuspid, mylohyoid, hypoglossal nerve, pterygoid, masseter, external pterygoid, palatoglossus muscles, most of his intrinsic muscles of tongue, hypoglossal, lingual, and inferior alveolar nerves, sublingual and submaxillary salivary glands, mucoperiosteum, and adjacent buccal and lingual sulcus mucosa. Features include speech, swallowing, saliva control, manipulation of food impaired, facial disfigurement of apparent, disarticulation and loss of muscles of mastication will hamper mandibular movements. Taste, sensory, and motor losses are more extensive as compared to class 1. Class 3, lateral resection of the mandible to the midline. Tissues resected all those dyes described in class 2 in addition to the anterior portion of the mandible, geniohyoid, glossus, remaining portion of mylohyoid muscle with lingual and buccal mucosa. Structures in class 2 are mylohyoid, hypoglossal, pterygoid masseter, external pterygoid, palatoglossus muscle, most of intrinsic muscles of tongue. Features. The most important is restricted tongue mobility due to loss of the tip of tongue and genioglossus muscle. Speech, swallowing, saliva control, and manipulation of food is severely restricted. Facial disfigurement is worse due to loss of anterior part of mandible. Disarticulation and reduction in amount of basal bone reduce prosthodontic prognosis. Scarring of orbicularis oris can interfere with expression of emotion. Lateral bone graft surgical reconstruction. That is a class 4. Lateral bone and split thickness skin or pedicle graft can be performed on patients who have had radical alveolectomies, dissection of mandible distal to cuspid with or without disarticulation, midline dissection with or without disarticulation. Three types of bone grafts are possible. There is the mandibular augmentation procedures, bone graft that connects a residual condyle with a large mandibular fragment, then lateral bone grafts that extends from the mandibular fragment into the defect area to establish a pseudo TMJ. Class 5. Anterior bone graft surgical reconstruction. Tissue resection. Anterior portion of the mandible, large bilateral portions of mylohyoid, geniohyoid, genioglossus, and anterior digestive muscles. Bilateral lingual and inferior alveolar nerves, bilateral submaxillary and submandibular salivary glands, mucosa of lower lip, anterior floor of mouth, and vertical surface of the tongue. The mucosa return and labial and buccal regions is sutured to the residual stump of tongue, and Kirshner's wire is often positioned to maintain the mandibular fragments. Bone graft and split thickness skin graft or pedicle graft procedures can be used to restore anterior facial contour in bilateral mandibular function. K-wire sterilized, sharpened, smooth stainless steel wire were introduced by Martin Kirshner's in 1909. Class 3. It is similar to class 5 patients, but the continuity of mandible has not been restored surgically. Because each lateral fragment moves independently, the prognosis for removal process is poor and fabrication is not recommended. Jeweler's classification of mandibular defects. Jeweler et al. In 1989 developed a classification that took into account the complexity of mandibular reconstruction. The classification is as follows. C. Central defects of mandible from canine to canine. L. Lateral defects extending from midline to the condyle. H. Hemimandibular defects including L defects of the condyle. Thus, these are the following defect variations of mandible: C, L, H, LC, HC, LHC, HCL, HH. Boyd's classification of mandibular defects. In 1993, Boyd modified the Jeweler's classification to include defects involving soft tissue resection. The classification is as follows. L. Lateral defects of any length up to midline, including condyle. C. Defects include central segment containing 4 incisors and 2 canines. L. Lateral defects including the condyle. Classification of mandibular defects by Arkan et al. This classification is based on functional considerations caused by detachment of different muscle groups and difficulties with cosmetic restoration. The classification is as follows. C. Condyle, R is for ramus, B for body, S for total symphysis, and SH for hemisymphysis. Now, predisposing factors, that is the dentures, chronic irritation, epidermoid carcinoma, squamous cell carcinoma. Alcohol. Squamous cell carcinoma is in floor of mouth related to direct tissue contact or indirect with liver cirrhosis and altered nutritional status. Tobacco, which includes cigarette, cigar, pipe, and chewing tobacco. Leukoplakia, white patch cannot be scraped off, reversed by removing local irritants. Oral lichen planus, reticular plaque and erosive forms. Factors affecting treatment of mandibulectomy patients. First is the local and extent of mandibular location and extent of mandibular defect. Radical alveolectomy. Least debilitating. Main problem is loss of vertical ridge height and vestibular depth. Decreased stability for soft tissue supported prosthesis as well as the loss of long bearing tissues available for support. Vertical discrepancy is most important when prosthesis supported by dental implants are considered. Discontinuity defects. Rule of thumb. The further anterior the defect, the more disfiguring and functionally debilitating it is like to be. Defects of the symphysial region. Most debilitating and difficult to treat. Greatest facial disfigurement are present. Surgical reconstruction necessary or at least segmental stabilization before personal treatment can be initiated. Mandibulectomy defects of molar region of mandibular body are more well suited for surgical reconstruction compared to anterior defects. If muscle attachments are intact, there is a good prognosis and near normal appearance and function is achievable. Presence of remaining natural teeth pre-existing implants. Patients after mandibulectomy present with few or no remaining natural teeth. Two reasons. Patients at greater risk for squamous cell carcinoma, heavy users of tobacco product and alcohol, then teeth are usually extracted prior to radiotherapy to prevent complications such as osteoradionecrosis. Greater the number of teeth, better the prognosis. Teeth present on both sides of midline permit greater prosthesis support since the problem of straight line design can be avoided. Maximum number of abutment teeth should be incorporated in the design of prosthesis to maximize stability and dissipate functional forces. If the patient has edentulous maxilla, a maxillary complete denture will function well for mandibulectomy patients against a reconstructed mandibular dentition. Exceptions are collapse of residual proximal mandibular stump, that is a coronoid process against the posterior maxillary alveolus, prohibiting adequate denture flange extensions. With a guide flange prosthesis is planned to correct mandibular deviation. Pressure from the guide flange will tend to dislodge the maxillary denture. Degree of post-mandibulectomy rotation and deviation. Loss of mandibular continuity causes deviation of the remaining mandibular segment towards the defect and rotation of mandibular occlusal plane inferior. Deviation primarily due to loss of tissue involved in surgical dissection. Rotation due to pull of suprahyoid muscles on residual mandibular fragment causing inferior displacement and rotation around the fulcrum of remaining condyle. Gravity, loss of anchorage of elevated muscles. Sequelae, facial disfigurement, loss of occlusal contact, loss of ability to bring lips together for saliva control and to initiate swallowing process. Prosthodontic prognosis in such patients can be improved by early post-resection physical therapy to reposition the mandibular fragment to a more normal position and to minimize scar formation that will make deviation more severe. Should be carried out as early as possible. After 6 to 8 weeks post-operatively, it will not be as beneficial. Can be in the form of physical therapy carried out by the patient himself, mandibular resection guidance prosthesis. The fourth point is available mouth opening. Trismus due to surgical trauma may occur. Scar tissue formation will further reduce mouth opening. Physical therapy is needed immediately. There is a stretching of the stretching exercise. Simple test to check mouth opening is insert a stock mandibular impression tray in the mouth. If this cannot be accomplished, rehabilitation is unlikely to occur. Surgery can be done to release scar tissue, uh, however, not very beneficial as it returns to the same in the short period of time. Fifth point is the functional limitation of the tongue. Frequently, the surgical wound is closed by suturing the remaining tissues of the floor of the mouth or tongue to the remaining buccal tissues. This compromises speech, swallowing, mastication, control of food bolus, ability to control removable prostheses. Lingual vestibuloplasty and skin or mucosal grafting can be used to improve tongue mobility. Evaluation of tongue mobility. Patients in whom anterior resection has been done, ability to lick the lips when the artificial process is placed in the mouth may be difficult or impossible. In such cases, consideration is given to lowering the anterior occlusal plane or arranging the teeth slightly lingually. Loss of sensory innervation will compromise tongue function and prognosis of prosthodontic rehabilitation. If lingual nerve is sacrificed, tongue on the defect side will permanently remain without any feeling. Loss of sensory capability affects speech, mastication, prosthesis control on defect side. Loss of sensory innervation of buccal mucosa, that is the long buccal nerve and lower left mantle nerve, will reduce patient's ability to control food and saliva. Sixth point is compromisation of the vestibular extension. Vestibular depth is critical for stability and peripheral seal. It is also critical when mandibular continuity is restored with bone grafting and implants are considered. Skin grafting. Skin grafts are used for surgical reconstruction either as lining for the surface of resected soft tissue or as part of skin and connective tissue grafts such as pedicle graft, free flaps, etc. Advantages. Effective load-bearing tissue can withstand pressure from prosthesis, protects underlying bone and connective tissue well due to rapid turnover of keratin producing cells. Disadvantage. No sensory innervation. Full thickness grafts may incorporate hair follicles. Skin is not very compatible with titanium surface of implants. Radiation therapy. Careful treatment planning is required for patients with radiation therapy. Irradiated tissue is fragile, sensitive to manipulation, desiccated, slow to heal, prone to infection, and at risk of osteoradionecrosis. So, altered anatomic relationship following restoration of mandibular continuity. Reconstruction of anterior defects and reconstruction of posterior defects. Reconstruction of anterior defects. Most difficult situation for grafting frequently results in a graft that is deficient anteriorly, results in a severe class 2 like situation. Prosthodontic difficulties in rehabilitating such patients are inability to provide proper lower lip support for aesthetics, speech problems associated with mandibular dentition placed too far lingually to allow normal articulation, inability to control food bolus due to lack of motor function of lips and muscles of the lower face. Excessive display of mandibular teeth due to patients' inability to maintain normal lower lip posture. Difficulty gaining adequate space for prosthesis placement without encroaching on function of tongue. Misalignment of remaining unresected mandibular fragments and resultant relationship between maxillary and mandibular teeth. Now, reconstruction of posterior defects. More predictable from prosthodontic point of view as compared to anterior defects. The mediolateral position of the graft is frequently seen lateral to the original position of the mandibular body. Thus, the prosthesis must be built in crossbite to maintain the denture teeth over supporting base of bone graft. This is the case in which partial resection of mandible is done. Angled dental implants in the prosthesis, their support can be a cantilever lingual to permit the tooth contact. These are the angled dental implants. Inadequate space after surgical reconstruction, it limits prosthesis or implant placement. Excessive space after surgical reconstruction, here the problem is to control forces on remaining teeth or implants. See, there is more space, more vertical height, which leads to more or increased crown height, implant crown height, which leads to more fulcrum or more vertical pressure on the implant. Immediate versus delayed reconstruction. Factors determining whether to construct at the time of tumor resection or as a secondary procedure are amount and character of remaining soft tissue, anatomic location of the defect, size of bone defect, general health of patient, prognosis for tumor control, experience of the surgeon. Extensive soft tissue loss require additional procedure for soft tissue augmentation, thus precluding immediate graft. If immediate reconstruction is desired but soft tissue appear adequate for proper watertight oral closure, a forehead flap may be useful. Flaps should be broadly based as thick as possible. The size and extent and prognosis of tumors requiring resection are important factors. Relative small defects needs immediate reconstruction. Spectrum malignant tumors requiring extensive hard and soft tissue resection with a radical neck dissection. Immediate implant followed by delayed graft. In medically compromised patients, observe the response to primary surgery before objecting to second procedure. Location of resection is another important factor. Defects at symphysis requires immediate stabilization or remaining mandibular fragments will collapse medially and superiorly because of muscle pull and scar contraction. Immediate stabilization is less important in lateral mandibular defects. Relating surgical considerations to prosthodontic treatment. Marginal mandibulectomy. Soft tissues are mainly used to reconstruct marginal mandibulectomies. They may be skin graft, local flap, pedicle flap, microvascular free flaps. Skin graft serves as excellent prosthesis bearing surfaces. However, when soft tissue bulk is required or recipient bed is previously irradiated, microvascular free flaps are the treatment of choice. Discontinuity mandibular. Previously, soft tissue local flaps, mainly the residual tongue suture to the bone of the defect, and pedicle flaps, pectoralis muscle, are used. MVFF have revolutionized the treatment of discontinuity defects. Microvascularized bone is mainly obtained from fibula, most common, and iliac crest. Soft tissue MVFF are obtained from forearm, rectus muscle. Now, mandibular malposition after bony reconstruction may be due to minimal proximal mandible on the surgical side to attach the bone graft. Mandibular segments are not stabilized and maintained in their preoperative relation to each other during grafting procedures. Delayed reconstruction may not be able to overcome scar tissue formation completely. Bone grafts used, that is the fibula and iliac crest grafts, have some inherent problems, that is lacks height compared to the residual mandible, pyramidal in shape, being narrower at the occlusal surface. Fibula is grafted to restore inferior border of mandible, which is necessary to restore facial form. This tends to place fibula buccally in the plane of cheek. Since bone is placed buccally, implant distal to premolar area cause constant soft tissue and infection problems.